Hello guys, I hope all of you are doing well, and I'm Dr. Ranjan, your pharmacology faculty. So guys, as you can see, we are already into the third week. So by this Sunday, we have completed G Pharma, autonomic nervous system, and cardiovascular system. Right, so today it will be the last day for CVS. And guys, I am having currently upper respiratory infection. So today in this video, you might find my voice to be muffled. I might not be as active as I am in my videos because I'm not feeling good. But anyways, I'm not doing it a live session again because on Sunday I might not be in the pink of my health, and I might not be able to do a live session because you know how these viral illnesses they can progress. So as of now, I'm still in the condition to record it, so I'm recording it and I'll premiere it, and so that your continuation is not affected week after week. So guys, what we are trying to do, many of you guys have messaged me that how beautifully this is working for you guys. I'm really happy. My main aim of doing these weekly sessions is so that you can master this subject, pharmacology, like any other subject which you are good in. So by the end of this exercise, no matter how weak you are in pharma, it would ultimately turn out to be one of your strongest subject, if not the strongest, one of the strongest subjects. And it will happen with time. The only thing we need is patience. Now guys, again coming to today's session in cardiovascular system, again I have made 15 new questions on CVS which you'll not find anywhere. They might be related to the PYQs, but they're not exactly PYQs, right? So again, I'll try to tickle your brain in this session. So guys, let's begin with the first question of CVS. All right, guys, so coming to the first question of cardiovascular system, as you can see here, the question is, all of the following side effect associated with amiodarone warrants its stoppage except. Now see, I have a couple of MCQs on amiodarone. If you have solved PYQs, you would witness that every year or second year, there is at least one MCQ from amiodarone. Now see, look at the options. Interstitial pneumonitis, B, hypothyroidism, C, optic neuritis, D, hepatotoxicity. So what is the answer, guys? First of all, you comment the answer, you commit to an answer, then I'll begin the discussion. So as I have said, nowadays the MCQs would be, more clinical related. So these are all side effects. First of all, to begin with, all of them, they can be seen with amiodarone. But the question is, with which one I have to stop amiodarone, probably, and with which one I can continue amiodarone. So which is the one with which I do not need to stop? Which one? A, B, C, or D? So I think most of you might have commented already, right? Now guys, here the answer is, see, many times in the questions, even if you don't know the answer, you can make a guess, a wild guess, right? So I know many of you guys would have guessed it as hypothyroidism, and your guess is not wrong. So if the patient develops hypothyroidism, then we will supplement levothyroxine, because hypothyroidism in itself is not a fatal disorder, right? Whereas interstitial pneumonitis, it can cause pulmonary fibrosis, it can be fatal. So I will stop it, amiodarone. Optic neuritis, it can cause vision loss, so I'll stop it, right? But there are few exceptions, I'll talk about that. Hepatotoxicity, I'll stop it, specifically if there is 2 times increase in ALT, AST, then I have to stop. Conditions applied, I have to stop specifically. Now it might differ from clinician to clinician. What guidelines say, more than 2 times increase, I'll stop it. Now optic neuritis, I don't need to stop it. I need to stop it because it can cause vision loss. But here, all of you know there is another side effect called as corneal deposits. Now remember guys, if there are corneal deposits, I have to see if the vision is normal. If the vision is normal, then you don't have to stop. Don't stop. If vision is normal, don't stop, right? Because a lot of times, most of the times, you'll find the vision is normal. If the vision is abnormal, there are halos or different signs and symptoms. In that case, you can stop. So there is one thing I want to tell you. If there is optic neuritis, I have to stop it 100%. Corneal deposits, not in 100% cases, only if vision is abnormal. Hypothyroidism, I don't need to stop it, but if there is hyperthyroidism, now in this case, it would depend upon the endocrinologist, right? We will take a consultation from endocrinologist if it develops hyperthyroidism. In this case, I might need to stop it. Why? See, hypothyroidism in itself is not fatal, but hyperthyroidism can be fatal. That is something I have taught you in Marrow, that if there is hyperthyroidism, it increases the risk of atrial fibrillation, and atrial fibrillation can get converted into ventricular fibrillation, causing cardiac arrest. That is the reason why, if there is hyperthyroidism, we can consult an endocrinologist. If he says we have to stop, we might stop it. So this is the MCQ, a new one which I have made based upon your clinical case. Now moving on to the second MCQ. The side effect seen in the picture is due to deposition of. Now this image has already been asked in AIMS. I have just changed the MCQ, keeping the image same. Melanin, lipofuscin, amiodarone metabolite, right? It is due to deposition of what? Now all of you know this is called as blue-gray pigmentation or ceruloderma. It is also known as blue man syndrome. And all of you know this is caused by amiodarone. This is caused due to amiodarone. So I would not be surprised if some of you guys would mark either amiodarone or amiodarone metabolite. But in both these cases, your answer would be wrong. So today in this question, you will learn something new, right? The reason why amiodarone causes this blue-gray pigmentation is not because of amiodarone per se, but it is mostly due to lipofuscin. So lipofuscin can get accumulated and it causes that blue-gray pigmentation that is seen. So I have said time and again, whenever you attend these sessions, you'll find some new information based upon which I'll make MCQs, because you know, when you go to the exams, all MCQs will not be from whatever you have read in your notes. There would be some bouncers, some googlies would be there. So in a similar pattern, I'll make some MCQs which are difficult. So this is a difficult MCQ and you might go wrong in the exam, but this does not mean I'll not attempt such MCQs. I'll attempt even if I'm wrong. That is what I need to do in a competitive exams, right? So if you're marked amiodarone, right, it is an innocent answer, but this is not the right answer. The right answer is lipofuscin. So you know, amiodarone is commonly asked. So that is the reason why I've asked this MCQ, going a little bit into more details of blue-gray pigmentation, right? Which of the following antiarrhythmic drug might have caused the change in the ventricular graph given in the picture, right? Now look at the option, look at the graph. Quinidine, ibutylide, lidocaine, flecainide. So here you can see there is QT prolongation. Now looking at QT prolongation, I would not be surprised if some of you guys would mark the answer as quinidine, but here, if I were to jump so quickly into quinidine, then it would not be the answer. So quinidine is a honey trap. And honey traps are always in option A, which are more lucrative. They will call you, aja, lekin wo bulaegi, lekin jaane ka nahi. You understood? So you have to be more careful while going for the answer. Now it cannot be quinidine. The reason being, quinidine is also a sodium channel blocker. So with quinidine, there would also be a delay in depolarization as well, which is not seen here. There is only delay in repolarization. That means indirectly the question is asking which is a potassium channel blocker among these questions. It's an indirect MCQ. And if you would have analyzed this particular information, you would have definitely landed on the right answer, which is ibutylide, which is a pure potassium channel blocker. So this is the graph of potassium channel blocker. Quinidine, it would have been quinidine if there would have been a delay in depolarization as well. So I think most of you would have done this question right, because it is a basic question. Quinidine has already been asked. That was a PYQ. I've changed that question and I've made a new question here. Now let's go to another question, guys. Another important drug. A patient of bronchial asthma is on theophylline. A normal dose of adenosine for treatment of PSVT will produce. Look at the options. Inadequate response, adequate response, toxic response, variable response. Now what is the answer? You can take some time, commit to an answer, and you can let me know the answer in the comment box. So guys, all of you must answer. If you are in this live session, you should answer. You should commit to an answer, right? Irrespective of, you might go right, you might go wrong. That does not matter. So adenosine. So this is a patient on theophylline. He was given an adenosine. What would be the effect of adenosine in PSVT? So it's a very simple question. If you understand that theophylline produces bronchodilation by phosphodiesterase inhibition, that is one mechanism. What is the second mechanism of bronchodilation produced by theophylline? It is block of which receptors? It is block of adenosine receptors. So Theophylline is an adenosine receptor blocker, and adenosine acts by stimulating adenosine receptor, isn't it? Adenosine acts by stimulating adenosine receptor. So just imagine I'm giving adenosine receptors are blocked. What would happen to the effect of adenosine? Will there be inadequate response? Will there be adequate response? Will there be toxic response? Will there be variable response? The answer is pretty simple. Now, by now, you should be able to answer. If you have not yet answered, please, can you let me know the answer in the comment box now, at least? The answer would be inadequate response. So this is one particular thing that we need to be careful about. So similarly, they can ask you, what can I possibly do here? Like, see, if there is a patient of bronchial asthma, then in that case, as it is, adenosine should not be used because it can also produce bronchoconstriction, right? And that is by stimulating adenosine receptor. So if there is bronchial asthma and PSVT, what is my drug of choice? If there is bronchial asthma, PSVT, what is my drug of choice? I cannot use adenosine. It itself causes bronchoconstriction. I cannot use a beta blocker. Do you remember the ABCD I have taught you? I've taught you ABCD, right? A for adenosine, B for beta blocker, C for calcium channel blocker, that is diltiazem, verapamil, D for digoxin. The preference of these drugs is ABCD. Now see, both adenosine and beta blocker produce bronchoconstriction. So whenever they ask you there is a case of SVT or PSVT, the patient also has bronchial asthma, in that case I'll go for C, calcium channel blocker, like a diltiazem or verapamil as a drug, right? So that is what we need to learn from here for future MCQs. Now this is MCQ regarding a drug that is frequently asked nowadays, sacubitril and valsartan. They're combined together for treatment of chronic CHF. All of you know this. I've taught you about sacubitril, valsartan. What is the mechanism by which both drugs are combined, right? As fixed dose combination in one tablet. So I'll take both these salts, combine them, make one tablet. Fuse at the molecular level. So I'm not fusing them at the chemical level. I'm fusing them at the molecular level and then synthesizing the drug. As two separate tablets in one capsule, there is another thing we can do. Either I can combine them in one tablet as two different powders, or make two tablets, put them into capsule. All of the above can be possible. I can use any one of these three. So what is the drug that is being available nowadays? Now again, this is an MCQ, which is not an easy one. It is a difficult one. But since sacubitril valsartan is being used, and there is a lot of controversy going on around this drug, not with respect to treatment, but the ethical and legal aspects of what it is called as patent, right? It should be off patent by now, but it is not yet off patent. That is the reason why I've asked the MCQ. So guys, if you don't know the answer, it's okay, it's fine. Today we'll learn something new from this MCQ, right? So comment one option. So just comment, what do you think? What could be the answer according to you? Then I'll let you know what is the answer. Now see guys, here the answer is B. They're fused at the molecular level. And that is the reason why normally we get a patent for 20 years whenever I design a molecule, right? So the company which designed the molecule, they took a patent for sacubitril for 20 years. Now, when the patent was about to expire, they took another patent for the process by which they have combined these two molecules. So no company can fuse these two molecules because they have patent on this as well. Now, we might argue it to be unethical. Is it unethical? Yes, it is unethical because patent should not be extended beyond that 20 years period. The reason being the poor people cannot get generic drugs which are much cheaper. So whenever drug companies use unethical means, so I'm not saying illegal. See, unethical is not equal to illegal. It's a legal means. But when the companies use these legal means, but they are unethical, I mean to say they are not, for the beneficial for humanity. Now, such a mechanism by which companies extend the life of patent of a drug is called as evergreening of patent. So when I increase the life of patent, so these drug companies, they run for profitability, but we have to strike a balance between profitability and humanity. I mean, we can debate whole day upon that, and we might not reach on an answer. But anyways, we have to solve MCQs if they ask you. So this is something I think they might ask you. How do we combine sacubitril and valsartan? See, everything regarding sacubitril, valsartan, I have taught you. You might have revised, right? So this is one point you can add to your notes. All right. Digoxin is a very important drug. So I made an MCQ, a new MCQ again, so they can learn something from this MCQ. A 57-year-old patient presented to emergency with ventricular tachycardia and expected cardiac arrest, means is highly likely that he might go into cardiac arrest. The dose of digoxin consumed is unknown. How much digoxin he has taken, we don't know. And as the number of digibind vials given to the patient is, how many vials can be given? 2, 5, 10, 20, right? So again, if you don't know the answer, just go for a wild guess what could be the answer. At the end of the day, you will come out learning something new here. So how do I give digibind? It has never ever been asked in your exam if I don't know the dose, right? So I'll tell you how to give digibind doses when I don't know the dose. So remember, in a child pediatric patient, we give 5 vials. In adults, we give 10 vials. If the patient already has cardiac arrest or there is a risk of cardiac arrest. So in this case, there is a risk of cardiac arrest. The patient is an adult, obviously. You cannot find a child 57-year-old, isn't it? So the patient is 10 vials should be given, right? Now, if there is no cardiac arrest, in that case, you can go for 2 vials. Now, if I know the dose, if a dose is known, if the dose of digoxin is known, then what is the way to calculate the number of vials? To calculate the number of vials, what I need to do, I need to multiply the dose into 0.8. 0.8 is the bioavailability of digoxin, and I have to divide this by a number 0.5, and you will get the number of vials, right? Now see, suppose I get the number of vials as suppose 3.75, then I will take the closer number. The number of vials should be 4.0 or 4 vials are to be taken. So this is how I can calculate the number of vials required for digoxin. So it is obviously based upon how much dose has been given. But you know, if I look at the clinical field, there would be many times when nobody knows how much dose he has consumed. The relatives do not know, the patient does not know. In that case, what I can do, I've told you. So again, we learned something new with respect to how digibind is given to the patient, right? Which of the following drug is used in heart failure, but it does not decrease oxygen demand by the myocardium, right? So simple MCQ, guys, is not a difficult one. It's a moderate MCQ at best, I can say, right? So look at the options: metoprolol, azosorbate dinitrate, ivabradine, melphalan. What do you think, guys? Does not decrease oxygen demand by the myocardium. Now look at the options, right? Look at the options. Think what could be the possible answer and commit to one answer. Right, guys, here, see, metoprolol is a beta blocker. It would decrease heart rate and contraction. That would decrease oxygen demand. Ivabradine is also going to decrease heart rate and decrease oxygen demand. So it is out. So you might be confused between B and C, isosorbate dinitrate. Now see, isosorbate dinitrate is a venodilator. It can decrease preload on the heart. And when I decrease preload on the heart, I also decrease oxygen demand. So the answer is milrinone here. So all of you know what is milrinone. It is an inodilator. So this inodilator, what it can do, it can increase contraction of heart and it also increases heart rate. So this inodilator, it would increase oxygen demand. That is the reason why I never use it in acute heart failure. I mean, sorry, not in chronic heart failure. It can be used in acute CHF. So in acute CHF, I don't have to increase the oxygen demand, but I have to increase contraction. Increase in oxygen demand is a side effect. It's not the main effect, right? But all these 3 drugs, they're used in chronic CHF, where my main aim is to decrease the oxygen demand to decrease mortality. So this is an MCQ. A similar MCQ has been asked in your exam. I just changed the MCQ into a different one. Now moving on to the next question, guys. A 65-year-old male is on amlodipine for treatment of hypertension. He presented to OPD with complaints of ankle edema. Which of the following management strategies should be avoided in this patient? Now again, see, if you look at this particular case, you will receive patients in your OPDs when you start on amlodipine with this particular side effect. It's very much clinically relevant. So last week I was taking an FMG class. A student came to me and with the same complaints, like his father, he was started on amlodipine and his father developed ankle edema. And he was asking me, sir, what could be done for this ankle edema? So I turned this into an MCQ here, which is pretty much logical, you see. Which of the following management strategies should be avoided in this patient? Stop amlodipine, switch to thiazides. Decrease dose of amlodipine and add thiazides. Decrease dose of amlodipine and add captopril. Decrease dose of amlodipine and add losartan. So which strategy should be avoided? So there are three things here which I can do. One which I should not do, which is not beneficial for the patient, right? So guys, take your time. It's a difficult one. But you'll learn something. How to manage ankle edema. Say ankle edema has been recorded, has been asked a lot of times, right? So it's but obvious. Tomorrow what they're going to ask? They're going to ask a new MCQ based upon how to manage ankle edema, right? Now see here, stop amlodipine and switch to thiazide. This is something I can do. Yes, I can do this. I can do this because I stop amlodipine. Amlodipine is gone. Ankle edema is gone. I'm starting thiazide and the blood pressure would be controlled. That is something I can think of doing. Decrease dose of amlodipine and add thiazides. Now see, this is something I should not be doing. This is the answer. The reason being, remember, you might as well think that thiazides are diuretics and they will decrease ankle edema. Remember, thiazides, they will have no effect. They will have no effect on ankle edema. The reason being, thiazides would be able to decrease ankle edema only if it is due to increased blood volume. And calcium channel blockers like amlodipine induce ankle edema. It is not because of increased plasma volume. I've told you this in my classes in Marrow. What is the reason of ankle edema? It is due to pre-capillary dilation. So plasma volume is normal. Capillaries are dilated. So capillaries have more blood. That is causing ankle edema due to movement of plasma into interstitium. Right? Decrease dose of amlodipine and add captopril. Yes, I can do this. The reason being, see, amlodipine and captopril. Amlodipine dilates pre-capillary. Captopril dilates post-capillary. So if I do this, BP would be normal because I have combined two drugs. Decrease the dose of amlodipine. Plus, if I dilate pre-capillary and post-capillary, plasma would be able to easily pass through the capillary. So ankle edema will go off. The same thing, yes, I can do this. I can start the patient on a RAS inhibitor. Add a RAS inhibitor. So I can also add losartan or captopril, whatever suits you and your patient. So answer is B. So I think the message is clear. What you can do is either you can stop amlodipine, start altogether a different drug, like I have started thiazide here because the patient is more than 55 years, right? Or I can decrease the dose of amlodipine, not stop amlodipine, and add something from a RAS inhibitor. Like I can add captopril, losartan, probably any one of these two because these are first line drugs. I can also use aliskiren. Nobody's going to stop me, right? But I should use either captopril or losartan because this is first line, not aliskiren because it is a second line. But if I'm using aliskiren, it does not mean it is wrong. It is also right. Okay. Now guys, moving on to the next question. A patient presented to emergency with high blood pressure and altered sensorium. All of the following drugs can be started immediately except. Now if there is high blood pressure, altered sensorium means there is involvement of brain and it might indicate towards development of hepatic encephalopathy. So first of all, I have to make a diagnosis. That what is this diagnosis? Probably this is the diagnosis of hypertensive emergency, where there is a very high blood pressure with some kind of end organ damage, right? Like it can be brain encephalopathy, retina, retinopathy, pulmonary edema, congestive heart failure, renal failure. These are end organ damage. So if there's hypertensive emergency, I have told you this, the drug I have to use is IV. Now this is how I should approach such questions. Whenever there is very high blood pressure, try to make a diagnosis. Is it a case of emergency or is it a case of urgency? If there is end organ damage, it is emergency, as it is in this case. If there is no end organ damage, it can be urgency. Now, in this question, now for me, what is left to pick up is which of the following drugs cannot be given by IV route. Look at the options: nicardipine, labetalol, Lasix, nifedipine. So if you have not commented yet, can you comment now? What could be the answer? So the answer would be nifedipine. It's an oral drug which can be used in hypertensive urgency, but it cannot be used in hypertensive emergency. So remember, I use nifedipine in hypertensive urgency by oral route. Mind it, oral. Sublingual nifedipine should not be used in case of hypertensive urgency because the sublingual route, the effect would be much more rapid, which I don't want, right? So oral is what is important here. Look at the next question, guys. A female on captopril presented with dry cough after 2 weeks. Which of the following statement about this side effect is false? So ACE inhibitors causing dry cough is a very frequently asked topic. So, manipulating this topic, I've tried to make an MCQ. So which is false? It is due to increased substance P, prostaglandins, and bradykinin. NSAIDs can decrease cough. Captopril, if stopped, cough will subside and then can be restarted. Captopril should be stopped and losartan should be started. Now look at these four options. Pick up one option, whichever you find to be the plausible explanation to cough, which is false, and comment the answer in the comment box, guys. Let me know the answer in the comment box. So I hope you guys have commented. Now see, there's something I've told you this, that the cough that is seen, it is indeedly due to these. Yes, it's correct. Because prostaglandins are involved, so there is some evidence that NSAIDs, specifically aspirin, can decrease this cough. Captopril, if stopped, cough will subside. Yes, it is yes. It is yes. But the second part is no. Then can be restarted is no. The reason being, the moment you restart, it will again have cough. So the answer is C here. So I should not restart ACE inhibitor. Captopril should be stopped and losartan should be started. This is something, yes, I can do that. Because ARBs, the risk of cough is negligible. It's very less as compared to ACE inhibitor. So guys, this is what we can learn from this. There is something else I can teach you from this question. ACE inhibitors induce cough is more common in female. Is more common in female as compared to male. That is the reason why I've taken the example of a female. It is usually seen after 1 to 2 weeks. Usually. But it can be seen after a month or 2 months as well. But usually, most of the patients, it would be seen after 1 to 2 weeks. So see, when you go into the clinical field, you are starting ACE inhibitor in your patient. If she is a female, expect cough in another 1 to 2 weeks. And what would you ask the patient? If you develop cough, then please come back to me so that you can do the needful, right? So answer is C, guys. Now moving on to the next question, guys. A patient of an acute attack of MI was given sublingual nitroglycerin, right? What is the use and mechanism of action? So the question basically is, why am I giving nitroglycerin in MI? And what is the reason behind it, right? So A, analgesia due to coronary vasodilatation. B, analgesia due to inferior vena cava dilation. C, analgesia due to increased myocardial oxygen demand. And D, anti-ischemic effect due to increased oxygen delivery to the myocardium. Now look at these options. Again, this topic has been asked in a different way. I made a new MCQ, right? Manipulating that PYQ topic. So if you have revised that particular topic with concept, then you would be able to answer this. So guys, let me know the answer in the comment box. What could be the possible answer? So yes. Now, if many of you think analgesia due to coronary vasodilatation is not. No. The reason being why I'm using it is because of analgesia, but the analgesia is not due to coronary vasodilatation. Analgesia is due to inferior vena cava dilatation, which decreases preload and decreases oxygen demand by the myocardium. So that is the reason why this is the answer. Analgesia due to increased myocardial oxygen demand, this is obviously an absurd option. It cannot be correct. Even if you don't know anything, this cannot be the answer, right? Anti-ischemic effect, increased oxygen delivery to the myocardium. Again, this is no. See, anti-ischemic effect is what gives us analgesia. So why do I get analgesia? Is due to anti-ischemic effect. But why do I get analgesia? Due to anti-ischemic effect. The reason why I get anti-ischemic effect is not because of increased oxygen delivery. It is due to decreased preload, decreasing oxygen demand. So option B and D are interconnected, but D is not correct. So B is the right answer, guys. B is the right answer here. Another new MCQ that I've given here, guys. Ranolazine is a drug used in angina. Its mechanism has been asked many times. I've just turned this MCQ into a more clinical one. What is the site of action of ranolazine in the ventricular graph given in the image? So you can see in this graph, I've given you 4 sites A, B, C, D. Where do you think? Where do you think it acts? A, B, C, or D? So this is an option. Even if you don't know the answer, comment the answer. All of you must have studied it, that it is a blocker of late inward sodium channel. So what is ranolazine? It is a late inward sodium channel blocker. Based upon this information, try to find the answer. See, this is A is not the late inward sodium channel. This is the peak inward sodium channel. This is the peak inward sodium channel. And this part is where it is early inward sodium channel in this initial phase where there is the dip is going on, slight dip, whereas the plateau phase from here to here, this is the late inward sodium channel, So ranolazine blocks this late inward sodium channel, this phase. So all of you know depolarization is because of this sodium, right? Whereas depolarization is maintained in the plateau phase, is maintained because of these early or late inward sodium channels. So ranolazine blocks these late inward sodium channels, because of which it also decreases calcium in the myocardium. If I decrease calcium, and that happens because of sodium calcium exchanger. So I've discussed that in detail in my lectures, how calcium decreases, what is the function of sodium calcium exchanger. We'll not go into those details since I've already taught that. Here our aim is to find out if they ask a graph, and in this graph they ask you where does ranolazine act. So guys, all of you know now your answer is option C. C is the part where it is acting, right? So again, it's a new MCQ which they can ask, and if they ask, you can always answer. Now look at the next question. A patient aged 27 years presented with isolated increased LDL, that is 167 milligrams per deciliter. What is the management strategy in this patient? Rosuvastatin 5 mg, rosuvastatin 20 mg, atorvastatin 40 mg. Don't start statin. Don't start anything. Now guys, what do you think is the answer? What do you think is the answer? So you see, I told you, I get cases, a lot of cases I get from students, right? So a student who came to me, again, last month, he came to me in between class and said, sir, my LDL is 167 and what should I do, right? What should I do? Though he had already been prescribed the drug, he was kind of wanted to get some revalidation from me. So what should I do? Now see, it's very simple. See, LDL lowering treatment, whenever I want to lower the LDL levels, there are two possible cases which I've discussed in my classes, main videos as well as revision videos in Marrow. If there is no ASCVD, means the patient is not suffering from angina, stable angina. He never had stroke or MI, but his LDL is increased. LDL is increased, but less than 190, as it is in this case. So it is more than 110, but less than 190. Second case is he has a clinical ASCVD, means either is having stable angina, or he already has MI or stroke, ischemic stroke, or there is no ASCVD plus LDL is too high, more than equal to 190. Now in these cases, two lipid lowering, LDL lowering agents are preferred, rosuvastatin and atorvastatin. Now you see at what doses I'm going to use. See, I use moderate doses for these cases. I use moderate intensity statin therapy. Here I use high doses or high intensity. How to remember these doses? Remember, rosuvastatin 5 to 10 milligrams. Double it, you'll get 20 to 20 milligrams. Double it, you will get 20 to 40 milligrams. Double it, you'll get 40 to 80 milligrams. So I've just now told you how to remember this statin therapy. So LDL lowering treatment. This is how I'm going to use it. And see, this is what you're going to use. So I told you earlier, they used to ask which is least potent, most potent, longest acting statin, but they refuse to ask such questions nowadays. This is how you're going to use a statin actually as a doctor in the clinical field. So they will ask MCQs on this particular aspect. That is the reason why I've made the MCQ with a kind of acquaintance I had with a student who had this. So based upon this, what should be my option? A, B, C, D. Guys, at least now can you comment and let me know the answer? right? Yes, tell me. So, if it is less than 190, plus he has no ASCVD, in this case, I'll be using moderate intensity. So here your answer will, sorry, your answer would not be rosuvastatin 20 mg. It would be not atorvastatin 40 mg. It would be rosuvastatin 5 mg, because these are high intensity. This is moderate intensity. Don't start statin is not the option, because long term statin use would be beneficial. Now coming back to the student, which I told you, right? Now the problem is when you get diagnosed with something which is bad from your health perspective and your age is so less, you kind of fail to acknowledge that I'm so young. How can I have such a disorder? And getting yourself mentally prepared to take a drug like statin is difficult. I understand that. So he was already prescribed rosuvastatin 5 milligrams, right? And he came to me. But he had not yet started rosuvastatin. He had not. He does not want to take rosuvastatin. So he told me, sir, I don't want. I won't take rosuvastatin. Can I take something else? Now, see, as a doctor, you cannot force someone to take a drug. At the end of the day, it is the patient's will, he or she wants to take the drug or not. Now, he asked me, sir, can I do something? So, see, I mean, if you cannot take statin, if you don't want to take statin, he wanted, can I do something with my lifestyle? So, obviously, all of you know about the lifestyle modification, exercise, diet, etc., etc. He asked me, sir, can I take some food specifically, right? So, the food that can decrease LDL is lemon juice. Lemon juice can decrease LDL. Now, this is something I'm not telling you to, write in your prescriptions, because if we start giving lemon juice in our prescriptions, the patient will go to a juice shop and say, I'll better go to a juice shop while I go to the doctor. I'm just telling you, I mean, you can search in Google about, there are articles on lemon juice decreasing LDL, and it does work. It does work. And it can decrease LDL. And I mean, it is not as good as statin. It should not be advisable. The reason being, statins have at least 7 to 8 more extra benefits than only decreasing LDL. Statins have anti-aggregant, anticoagulant, plaque stabilizing. So these are called as the other effects which can be seen with statins, right? Pleiotropic effects. So I told him, so this is, say, if he came to me asking something, can I do? So I advised him this, because at times, we cannot take a drug and shove it down the patient's throat, right? Now let's move on to the next question. A patient on routine examination was found to have serum LDL levels of 210. It's very high. Triglycerides is also high, 400. He has no history of coronary artery disease. Which of the following management strategies should be followed? Rosuvastatin 40 mg, rosuvastatin 40 mg plus fenofibrate 67 milligrams. Fenofibrate 67 milligrams. No drug should be started. Option D is absurd. You have to start something. What should I start? What should I start? Just ponder upon the options. Let me know the answer in the MCQ box, in the comment box, guys. So I hope you guys have commented. Commit to any option of your choice. Now again, if triglycerides level are increased, the treatment is not as simple, right? I have to assess the risk of ASCVD in that patient. Does he have a high risk? Now, when the LDL level is so high, obviously he has a risk of atherosclerotic cardiovascular disease. So if risk is present, guys, I'll start the patient only on statins. Only statins. Why? Because statins can not only decrease LDL, they can also decrease triglycerides. Now, if I start on statins, then I will repeat the LDL and triglyceride level. It might be possible that with only statin, I might be able to decrease his triglyceride levels, right? Now, even if after giving statins, if triglyceride is high, then I can think of adding a fibrate, right? If it is significantly high, and I think that he might be at risk of pancreatitis. If there is no risk of ASCVD, like for example here, if I would have given that the patient LDL level is normal, then there is no risk, right? But if I have given here no LDL level, but I just would have said that the patient is suffering from stable angina. Again, stable angina is itself, there is a risk of ASCVD. It is itself a clinical ASCVD, isn't it? All right. So level is 2. So what should I use here? Now, look at the option. Look at the option. So yes, here my answer is A, rosuvastatin 40 mg. LDL is 210. And again, if I go back, I told you more than 190. Then if I'm using rosuvastatin, I'll be using 20 to 40 mg. So the answer here is rosuvastatin 40 mg. So these are clinical MCQs which can be asked. Finally, guys, we have come to the last MCQ for today's session. Which of the following drug acts by decreasing synthesis of PCSK9? Come on, comment the answer. Let me know the answer in the comment box. And I hope all of you might have jumped onto the honey trap that I made for you guys. Most of you would have answered evolocumab. It is a wrong answer. It is a wrong answer. I see. You would have looked at PCSK9 and you would have thought, sir, क्या मजाक है, इतना आसान क्वेश्चन दे दिया सर. PCSK9, it has just been asked in INICET and the answer was evolocumab. But what is evolocumab? Evolocumab is a blocker of PCSK9. It is a blocker of PCSK9. It does not decrease synthesis of PCSK9. So you've lost the battle not to pharma, you've lost the battle to English language, right? As it happens a lot of times. So answer is inclisiran, guys. So inclisiran, what is inclisiran? S for small, I for interfering, R for RNA. It is a small interfering RNA. AN means, in pharma, AN means antagonize. So what it does, this interferes or blocks the RNA which is required for synthesis of PCSK9. So it blocks RNA, not PCSK9. And once it blocks RNA for PCSK9, what it does, it blocks or decreases synthesis of PCSK9. So again, this is a new drug that can be asked. And in INICET specifically, they will throw such kind of googlies where you mark the option, you're damn sure that you're right, but it is not. This is the reason. So guys, that's all I had to offer today. I had made this bunch of 15 MCQs and these are new MCQs. I took a lot of time to create them so that I said my aim is to tickle your brain. My aim is to teach you something new in these sessions that I can add on so that it can help you not only in NEETPG and FMGE, it can also help you in INICET. So any exam you're preparing for, these sessions will be helpful, right guys? And as I said, if these sessions are helping you, please let me know in the comment box. Your comments, they're inspiration for me that I can do much better and better, work harder to bring you something new, some new MCQs for you guys. So many of you guys have commented you are not on Instagram. There is a reason why. For next central nervous system, I'm giving you the schedule in this session itself. So whoever is not on Instagram, you can take a screenshot of this and I'll post on YouTube as well. So guys, all the best for the next next session, that is central nervous system, for next week. Read. So you see, bit by bit we have covered G Pharma, ANS, CVS, and all of you who have been following it thoroughly, I'm really proud of you guys, because see, this thing is amazing, but it requires a lot of patience to do this for so many months. And obviously I cannot do it for each and every subject. I can do it for 2 to 3 subjects, which are my weakest one, so that they get converted into my strongest subject. And if you had been following this up for these many weeks, then kudos to you, right? That means you have a lot of patience going forward. So guys, that's all for today's session, and I'll see you next week, guys.